Afternoon, HCA family, and welcome to today's webinar, Mental Health and COVID-19 Special Topics for Caregivers of High-Risk Populations. We have a diverse group on today's call, and for those of you who may not know me, my name is Carrie Thrush, and I will be the moderator today. I work on the client experience team, and I'm very excited to be hosting today's session. I'm pleased to introduce today's speaker. We have Dr. Nicole Ionescu. Dr. Ionescu is a UCSF-trained clinical neuropsychologist with over 15 years of experience in neuropsychological evaluation, diagnosis, and treatment of patients with developmental, age, and trauma-related neurocognitive challenges. Currently, Dr. Ionescu is the staff neuropsychologist in the Department of Neurology and Neurosurgery at UCSF Bennett Children's Hospital in Oakland, California. In addition, Dr. Ionescu has a background in teaching, co-authoring medical journals and magazine articles, and is a researcher in clinical trials. We do have the great honor to have her speak today on the increased mental health concerns that pandemics can have on the elderly, and the importance of self-care for all of you working so hard and vigorously for the clients that you serve on a day-to-day basis. Before I do hand things over to Dr. Ionescu, I have a few housekeeping items to cover. So first, today's webinar is being recorded and will be provided to all of you afterwards. So for anyone who would like to listen back or has missed the live session, you can do so. Next, we'd love to hear from you during today's presentation. If you have any questions for our speaker, please feel free to send them through in the chat, and Dr. Ionescu will be answering questions at the end of her presentation today. So without any further ado, a very warm welcome to you, Dr. Ionescu, and I'll hand things over to you.
All right, thank you so much. That was a very nice introduction. So today I do want to talk about just some very broad topics related to mental health and COVID-19. And of course, this is something that we could probably literally talk about all day and not be done. So I do want to just kind of give a broad overview of the things in my population that I have been seeing. So as Carrie said, I am the staff neuropsychologist at a children's hospital, but in my private practice, I focus on geriatric population. So I have a couple of other neuropsychologists that work with me. And so we really, between all of us, are seeing kind of the broad spectrum of how this is affecting groups from children and their parents all the way through a geriatric population. So what I would like to do is just kind of talk at the beginning about life in a pandemic, because when we think about social isolation and mental health, I mean, it's clear, we don't, need to belabor that point. When social isolation happens, there's going to be mental health consequences. I think the bigger issue is that research is showing us that certain groups are at higher risk for poor mental health outcomes. So children and adolescents, older adults, minority groups, those from lower socioeconomic groups, women, and those with pre-existing mental health conditions. So if you take a minute and think about your caseload right now, I would bet you that many of your patients fall in multiple of those groups. So that's true with older adults. Many of them already had pre-existing mental health conditions. They were in minority groups. They were from a lower socioeconomic status to begin with. So now we have this confluence of a population that covers many of the different high-risk categories, and we are expected to identify and treat these individuals during these challenging times. And I will say, as a caveat, when I talk about research, we're looking at two kind of groups of research. So obviously, COVID is new. So the research that's coming out in 2020 and maybe late 2019, a lot of it is case study research. A lot of it is really specific groups. Of course, as time goes by and we understand the natural history of COVID a little bit better, research is going to continue to grow and grow. But a lot of the research that we have now comes from the SARS outbreak in the early 2000s and what we learned about social isolation and pandemics and how that affects people. So it's kind of a mixture of both. And I don't know if many of you know this right now, but most clinical journals that normally would have charged for full copies of research. When it's based on COVID, they're giving the PDFs for free. So when you look at some of my references, if you go look up those articles, most of the PDFs right now are free. So that's nice, and just a little tip here. So when we think about social isolation, I want to think about it in a couple of different ways. So we know it affects the psyche, but it also affects the brain at a subcortical level. And there are many different ways that this happens, but this study that I found out of the University of Chicago that took place late in 2019 was looking at how the brains of lonely people versus non-lonely people react to different kinds of stimuli. And I thought it was super interesting. So I just wanted to touch base because, again, there are many studies like this, but this gives kind of an overview of what the brain does when it's socially isolated versus when it's not. So what they did was they put people in a functional MRI machine and they had them view pleasant pictures versus unpleasant pictures. And they found people who identified as socially isolated and lonely versus people who identified as feeling socially satisfied and not lonely. So when viewing pleasant pictures, non-lonely subjects showed much more activity in a section of the brain called the ventral striatum. So the ventral striatum, if you look over at my little graph, it's a subcortical structure, meaning it's deep within the brain, and it is how it plays a role in learning. So when we see new images and when we get new information, our brain organizes it in schemas. That's just how the brain works. So when viewing pleasant pictures, the people who were not lonely, they were able to learn and remember that pleasant feeling. Whereas people who were lonely, that part of their brain did not light up when they saw pleasant pictures. Meaning when something pleasant happens, if you're coming at it from a place of depression and loneliness, you're less likely to remember it than something not pleasant, which I think is super interesting. And then the other thing they did, what they saw, was when non-lonely subjects viewed unpleasant pictures, they demonstrated activity in the brain of the temporal parietal junction, which is associated with empathy. And the lonely subjects had a lesser response. So the reason I thought that was really important is because when you think about the way that human beings connect with one another, one of the main ways they do it is by empathy. So if I have empathy for you, and if you have empathy for me, we're going to feel a deeper level of connection. So if you are lonely and depressed and you see a sad picture and you're unable to engage the part of your brain associated with empathy, it's going to make it very hard for you to feel connected to other people. So again, I think that we could, again, talk the whole time about this, but I wanted to bring it up because I think it's a good reminder that while a lot of the mental health issues are happening on sort of a higher level of emotion, there's also a lot that's happening on a deeper level within the brain that I think is important to remember. So given that we know the brain and the psyche are impacted, I think we have to consider three things today that we should just try to talk about in broad strokes. So specific increased mental health concerns in the elderly, some intervention strategies, and then self-care and protection for ourselves, because this has been a very difficult time, not just for our patients, but for us as well. And with the intervention strategies, I want to touch a little bit, which we'll get to, on telemedicine. And I did put some resources in the presentation, and just to remember, of course, that it's different for every state, every licensing board, and we'll talk about some of the ethical considerations with that as well. So in terms of mental health, I thought we would start with talking a little bit about PTSD. So pandemics are traumatic, sheltering in place is traumatic, social isolation is traumatic. And anytime somebody is faced with a situation where they feel as though their life is being threatened, there's a high risk of developing PTSD. I think this is a particularly difficult time because not only are people feeling as though their lives are being threatened, but in many cases, their livelihood, their retirement, the lives of those they love, their way of life. So there's certainly a lot here to unpack in terms of trauma. So I think understanding who in our case population is at greater risk is important so that we can identify those people early and provide intervention and treatment. So much of what we know comes from research conducted after the SARS outbreak. I found an interesting study conducted by Lau in 2004, who's a researcher in Hong Kong. And what Lau's group did was they gave surveys out to the residents of Hong Kong after the SARS outbreak. And what they found was that 65.4% of residents felt helpless. 55.5% felt horrified or apprehensive, and 48.4% found that their mental health had severely or moderately deteriorated because of the epidemic. So that's a huge number. For 65.4% of people to say that they feel helpless is significant because helplessness is such a big part of the basis of depression, of anxiety, and of course PTSD, because the whole issue of PTSD is that when you feel like you've lost control and you feel helpless, that's when the anxiety really sets in. So I thought that was a very interesting study. So, level of exposure is also something interesting that pops up in the research. So, older adults are more likely to report PTSD symptoms than middle-aged adults. And partly living in highly affected areas is an independent risk factor for PTSD, particularly in a geriatric population. So, what I thought was interesting about the research here is that even if the individual and those who are close to them do not contract the disease, the risk of PTSD was higher. So if you think about older adults, they're really vulnerable here because if you live in a boarding care, if you live in a SNF, if you live in assisted living, the risk of your area being affected is higher because if one person gets COVID, it's so much more likely that other people will get it. So if you take that by itself, and then if you live in a hot state like New York, Washington, now California, Mississippi, you're already at risk twofold because you live in a contained environment where if one person is infected, more people will become infected, and then you live in a place that is already highly affected with regard to your state. So even if you don't contract it, you are feeling more anxiety about it. And then for those unfortunate individuals who do contract COVID and have to be hospitalized, of course, there's going to be trauma and psychological dysfunction related to that traumatic experience of being treated in a hospital setting. So there's a recent study that looked at 714 clinically stable COVID-19 patients from temporary quarantine hospitals, and they gave them the PTSD checklist, the civilian version, and 96.2% of them at the cutoff score for probable PTSD. And of course, there are other outside factors, related to fear of death or dying, premorbid poor physical functioning. But if you think about a geriatric population in particular, there are already so many of these issues happening. The fear of death or dying, of course, age, premorbid poor physical functioning. So again, looking at your patient caseload and saying, who's at risk, who should I be watching, who should I be pushing some of these interventions on before things get out of control, I think is a really big part of this. So again, just to review some of the things that we've talked about, the possible risk factors for PTSD and chronic psychological dysfunction would be isolation, social inequalities, living with a disability, gender, and age. So of course, increased age. The research shows with regard to gender that women in this situation are more likely to develop PTSD. But I think the issue is, as anytime we talk about women seeming to develop psychological disorders more than men, it could just be because they're more comfortable discussing their symptoms and they're more comfortable asking for help. But I think it's important to take a look. So I wanted to, throughout this talk, throw in a couple of case studies to just sort of illustrate what I've been seeing in my practice as it relates to some of the research we're talking about. So when I was thinking about a case for this little section on PTSD, this woman I've been seeing, Anna, and of course all names and identifying information have been changed, but this woman, Anna, who I was seeing. So Anna is a 60-year-old female, and she came to me for neuropsychological testing in late 2019. She had been in a motor vehicle accident, and she was having post-concussive symptoms. So her neurologist sent her to me for neuropsych testing and treatment. So I did the testing, and she met criteria for post-concussive syndrome. We started doing Zoom therapy. She started doing OT and PT. She's an extremely resourceful woman, and she found some meditation groups, and she was recovering. Things were kind of chugging along. And then the pandemic hit, and her elderly mother's caregiver stopped coming. So Anna's mother, unfortunately, was in her 90s. She lived nearby Anna. She had fallen and broken her wrist on her dominant hand, and she required surgery. So there was sort of the 6 weeks leading up to surgery, then recovery. So she already, and the woman already had some other issues, and she couldn't live by herself. So Anna's siblings said, well, you're already on disability for your concussion. Why don't you go take care of mom? We're still working. So Anna went to live with her mother, and Anna was an RN herself, and she was already on disability due to her concussion. And so once Anna left her home, so she was, at home with her family. One of her adult children was living there with her grandkids and her husband. So she was used to a house full of people. And then she went to live with her mother, and her isolation increased. So Anna had been engaging in PT and OT, both of which had switched to telemedicine, but she found herself canceling appointments to care for her mother. So she had also found a meditation group that switched to online. She had joined a virtual book club. She had been doing all of the things that we had been talking about in her therapy to keep herself healthy, but all of that got disrupted by the disruption of her mother's care due to the pandemic. So Anna started describing to me in our sessions that she was exhausted. She started having nightmares. And what was interesting is that she started having nightmares about the car accident that happened in 2019, which gave her the concussion, which she had previously not had nightmares about. So clearly something in the anxiety of caring for her mother was triggering some of the old underlying anxiety from the car accident. So she was already at high risk for PTSD, and the disruption of her mother's care due to the pandemic increased her risk. So unfortunately, I'm still seeing Anna, but the last few times I've spoken to her, she's again, just exhausted, mentally foggy. So I'm really working with her family to get her siblings to help her take care of her mother, because they still can't find a caregiver that will come in and do that. So the reason I bring this case up is because it's a really good example of somebody who didn't get COVID. Her mother didn't get COVID, but she's still really impacted by the pandemic, and she was already at a high risk, in a high risk category. All right, so beyond PTSD, oh, I'm sorry if you hear my dogs in the background. They're supposed to be quiet, but we'll see what we can have them do. So beyond PTSD, so there's implications for general mental health. I don't know about you, but when someone says to me, fine, when I ask, how are you? That really worries me. So I like this little graphic, because when I hear someone say fine, that's all the things that I think they might be feeling: confused, broken, never good enough. So I do think that there are other issues we have to discuss here. So there's higher levels of stress and anxiety, and depression, obviously predicted in the wake of a pandemic. And it's also expected that individuals with chronic illnesses will present higher levels of psychological symptoms, which of course, again, is going to be so much of a geriatric population. So if you came into this with a chronic illness, you're going to have higher levels of psychological symptoms. So the next topic that has come up in my work, and I'm sure it's come up in many of your work, is the suicide risk. So the elderly are particularly susceptible to the adverse effects of isolation. So living alone, loneliness, and social isolation are well-recognized risk factors for suicide later in life, regardless of a pandemic. So these are things that we know are increasing the risk of suicide. So even before the pandemic, older adults living in senior communities that were designed to reduce social isolation still described a moderate level of loneliness. So even when people were living in a place that was meant to decrease their social isolation, there's still a moderate level of loneliness. So the interpersonal theory of suicide suggests that suicide may be the result of thwarted belongingness and perceived burdensomeness combined with acquired capability for suicide. So if we think about this, you know, belongingness, feeling part of a group, when that gets interrupted by anything, as well as perceived burdensomeness. So you feel that you're a burden to your family, you feel you're a burden to the healthcare system, you feel you're a burden to your caregivers. These were things that were already happening. And now the acquired capability for suicide comes from something like a pandemic, comes from being even more socially isolated. So you kind of already had these interpersonal issues before, and now there's an outside factor that has increased your capability for suicide. So following this theory, older people are especially vulnerable because of disconnectedness from society, physical distancing, loss of usual social activities, and fear of burdening society with increased healthcare needs. So again, these factors below are going to be the acquired capability for suicide in this interpersonal theory where there already was perceived burdensomeness. There already was this sort of sense of feeling disconnected from other people. So a case study that came across my mind when I was doing this section was a woman named Edna who came to see me over Zoom for therapy in March. So she's a 91-year-old female who presented with depression and increased suicidality. So early in March 2020, before the shelter in place, Edna had moved to a new residential care facility because she'd fallen multiple times and felt unsafe living alone in her home of 35 years. So she had been in her house for 35 years. Her husband had died maybe 20 years before, and her children had kept telling her, it's time to move, it's time to move. And she had fallen quite a few times. So finally she said, okay, I'll move. So in mid-March, when the shelter in place began, her facility really locked down, so she couldn't leave her room. Dinner was no longer served in the dining room, and all social activities had been canceled. So this was particularly distressing to Edna because she didn't know anybody when she moved into this facility. So not only was she dealing with the loss and grief and the transition of moving out of her home, she was just starting to make friends. And for her, the main way she made friends was she was eating every single meal in the dining room. She was trying to sit with new people. She had joined a couple of social activities. And so all of that kind of got pulled out from underneath her. And she was stuck now in this room by herself without really knowing anybody. So she reached out for telemedicine therapy to manage increased depression. And when I asked her why therapy now, she was very blunt and said, I want to jump off my balcony. And if I get this thing, meaning COVID, I'm not going to make it out alive. So she really felt like if she got COVID, she was not getting out the other side of it. So she was taking the shelter in place very seriously, which unfortunately was making her socially isolated and depressed. So we started weekly telemedicine therapy with a focus on coping skills and opportunities for socialization in her limited environment. So what was good for Edna was that she is very cognitively sharp, and she's very good with technology. So even though physically she was having balance issues and was falling a lot, cognitively she was very sharp. So we were able to I was able to show her how to set up virtual book clubs and exercise groups and yoga classes. And she was starting to do that, but still there was this feeling of despair that she really, continues to feel that she's not going to come out of the other side of this pandemic. So we are definitely working on managing those fears with her. Okay, so I want to touch base a little bit about dementia and the neurocognition of COVID-19. So, COVID-19 is so new that from a neuropsych perspective, there's not a ton of research on what it's doing to people from a neurological perspective. I think that, what we're seeing in the research is a lot of case studies, a lot of incidental findings where people are talking about when they have COVID-19, how they feel like they're in a brain fog. Now that could be from sheer exhaustion. It could be from, some of the depression and PTSD we're talking about, but I did want to touch base a little bit about specific concerns related to dementia during this pandemic. So patients with dementia, one of the issues is they might have trouble remembering to follow the CDC guidelines. And even if they do remember, sometimes there's a decreased ability to engage in motor activities related to safety. So I just wanted to, this is like a really short little case study, but I think it's relevant. So there was a woman, Michelle, who was referred to me for neuropsych testing for pre-surgical testing during this period. And so certain tasks had to be completed in person. So that has been the challenge in neuropsych, is that there's certain parts of it you can't do remotely because there are materials the person has to manipulate. And so while we are able to push most of it, there are some things in terms of pre-surgical care that that have to be done in person. So I brought her into my office, and the problem is she was unable to keep the mask on her face. She kept pulling it off, and then she didn't have the motor dexterity to put it back on. So her husband was with us in the room, and he kept putting it back on her, but literally he would put it back on her, remind her, you can't take your mask off, and she would say, okay. And then 3 minutes later, she would take it off again, and then she was unable to put it back on. So then we moved to telemedicine, and even with her husband sitting next to her, she kept accidentally hitting her hand on the computer and disconnecting the call. So we would have to keep restarting it. So I think she's a good example of, we're trying to get this neuropsych done. I'm trying to do these interventions and treatments because her neurologist needs them before her surgery, but she just didn't really have the cognitive wherewithal or even the motor dexterity needed to even get through a telemedicine visit without accidentally knocking the computer over or hitting the keyboard or disrupting the call. So kind of in that same vein, specific concerns related to dementia. So in group and assisted living homes, in some cases, it's impossible to avoid touching. I mean, people need assistance with bathing and dressing. And I think the other thing is there are staff that work in multiple settings, that work across different populations in different homes. And so it's very hard to keep things contained. And also social isolation and the agitation involved with demands of increased hand washing and lack of activities and treatments may worsen cognitive symptoms. So that's like the case with Anna that I was telling you about earlier. She was getting better with OT and PT and therapy, which at least we're able to continue her therapy. But she started to worsen because of the demands placed on her by caring for her mother, but also, I think, because her OT, which was really a cognitive rehab focused OT, was disrupted. And then, of course, in long-term care homes, as we've seen, once one person gets COVID-19, there's a high attack rate and case fatality rate. I found one example of a long-term care in Washington state that had 34 fatalities among 101 affected residents, and 50 healthcare workers were infected. So this is a difficult situation for people who with dementia who are not able to go home, who have to stay in long-term care facilities where we know that the rate of attack is high and there is a disruption of care. So in terms of the neurocognitive effects, again, I don't want to dive too deep into this one, because I think we're still learning so much about the natural history of COVID and how it affects the brain. But I did want to talk to you a little bit about some of the research that I found here. So the hippocampus, which is the part of the brain responsible for, among other things, memory and the processing of new memories, appears to be particularly vulnerable to corona infections. So this increases the probability of post-infection memory impairment and then the acceleration of neurodegenerative disorders such as Alzheimer's disease. And then this was another little interesting tidbit I found based on a case study that was written up recently. So some research in 2020 based on COVID has showed that on remotely administered neuropsych batteries, patients have a trend towards significant differences in reaction time and processing speed. So the patients with COVID tended to complete the batteries okay, but they did it at a much slower time and their reaction times were much slower, which I thought was interesting. And then there was some theory here and some hypothesis that even that when patients recover from COVID-19, there's an underlying inflammatory process that happens, which makes it hard to fully recover cognitively. And I don't want to get too deep into this. You know, I put the citations here for those of you who are interested. You can read more about this, but acute necrotizing encephalopathy is a rare condition related to influenza. And so when this happens, it can cause what's called a cytokine storm, which is when your body is inflamed by something like COVID virus or coronavirus. And so your immune system starts to attack itself, and this passes the blood-brain barrier. So this can really cause brain damage and altered mental state. And there was one case study of a female airline worker in her late 50s. She presented with a 3-day history of cough, fever, and altered mental status. And her initial laboratory workup was negative for influenza, but positive for COVID-19. So when you looked at her CT images, she had issues in her medial thalamus or medial thalami, and then she had some hemorrhagic rim enhancing lesions within the temporal lobes and the thalamus. So again, these are the deep structures of the brain that I talked to you about earlier in the very beginning of this presentation, where we have memory and empathy and some of our ability to learn and process new information. So this is, again, a case study. I think we're still at the very beginnings of understanding the neurocognitive effects of COVID, but I do think that given the population of patients we see, if somebody comes in and they have an altered mental status, to not just automatically think it's some sort of delirium, that it could actually be a symptom of COVID-19. So after identification, treatment and intervention in the time of a pandemic. So telehealth, which I'm sure we're all more familiar with now than we ever wanted to be in the past, is the main way that we can get care to people. So I want to talk a little bit about that. So telemedicine allows for patients to access mental health during isolation. It opens the door for increased support. And interestingly, in my clinical practice, I really feel like there are patients who are reluctant to come in for psychotherapy because the feeling of coming into a therapy office was really intimidating, but doing it with the barrier of a screen in their own home somehow feels safer. So one, my no-show rate has gone down to practically nothing because people are at home and they have no problem showing up for their appointments, which consistency in mental health is great. But also, I think it takes away kind of the fear and the mystery of therapy, and people that didn't really want to do it before because it seemed so intimidating are much less intimidated and are able to access it in a way that they couldn't before, which I find interesting. But what I do want to talk about too is further advances in telemedicine. So the issue with telemedicine right now is that it's typically one-to-one format. So you're in a situation, I think, as a mental health care provider where you now have this huge burden of people who need your help. And now there's nothing standing in the way really of them getting it if they have access to technology, because they don't need to drive anywhere. They don't need to rely on some sort of transportation to get them somewhere. And if you are seeing patients beyond your normal hours that you would see people, now you even have longer days that you can treat people, which is a good thing, but it also makes it hard to put good self-care boundaries on how much you're willing to see patients. I mean, you could easily fill up your day with telemedicine therapy if you wanted to. But I think we need to move more towards an asynchronous situation. And what I mean by that is using the one-on-one telemedicine as the first step, but helping patients access all of these digital apps that are out there, like Calm and Headspace. And there's so many now, different meditation apps they can do, different, brain training apps they can do. So I think where we're going to need to go, this is just kind of my opinion, is mixing synchronous telehealth with asynchronous, because it is not possible to think that we could see everybody in a one-on-one format all the time. It's just too taxing on the healthcare system. But I think that there are these other tools out there, and also increasing the ability to do HIPAA compliant group therapy over telemedicine, I think is going to be really important. And again, I just want to touch on this, and I put the resources on the bottom because I know we're here from all different states and we're all different, we're all governed by different licensing boards. So when you're doing telemedicine, just check your board requirements, state of license versus state of residence. Usually they have to be the same. HIPAA compliant systems. So I know the Board of Psychology has said you can use Zoom, you can use, Theranest, but you can't use things like Facebook chat, you can't use other systems. So I think just to make sure that if you're doing telemedicine, that you're using a HIPAA compliant system. And then consenting for new patients. So verbal consent until you're able to see the person in person, or you're able to mail them or scan and get to them a actual signed consent is usually okay. But again, I would just check with your own state licensing board how they're handling informed consent for telemedicine patients. And then insurance issues. Medicare has been really great about, and TRICARE about reimbursing telemedicine, but I think every insurance company is different. And then, of course, confidentiality. So if a person is in a situation where they're doing telemedicine with you and it's in a big room with other people that can hear, I think we just want to make sure that we protect our patients' confidentiality. So again, those are just some resources for you. I think it's just best to check before diving into some of the telemedicine. Okay. So finally today, I want to talk about the impact on the healthcare workers. So this is an overwhelming thing that has happened to all of us, I think on a professional level, but also on a personal level. And I know that everybody works for different hospital systems, different institutions, and I think that there is a lot of pressure about the number of cases you're seeing. There are some hospitals that people have been going into work every single day during this whole thing. Others, it's a mixture of telemedicine and in-person visits. I know that there's some people who probably feel pressure to go in and see patients in person when they are not sure that it's safe, and the fear associated with that. So experience from the SARS and H1N1 epidemic underlie the psychological strain on healthcare professionals. And in the early rapid expansion phase of the SARS outbreak, similar to the current COVID-19 pandemic, healthcare professionals reported feelings of extreme vulnerability, uncertainty and threat to life, somatic and cognitive symptoms of anxiety, and moderately high anxiety and subsequent psychological distress. So I think that knowing these things are normal and understandable, and that we've all probably experienced some of these or all of these during this, and just I think to normalize it and to realize this is major what everybody's going through and the different demands that are placed on all of us. So what I really liked, Greenberg earlier in 2020 came up with 6 elements in terms of protecting healthcare workers. So this will be, some of this is directed towards those of you who are managers and you're looking at your staff sort of thinking, how can I make people feel protected? How can I make people feel taken care of? And the first one is healthcare workers should be appropriately thanked, and just acknowledgement of the challenging work undertaken can foster resilience. And given that avoidance is a key symptom of traumatic stress, it is important that if you have staff that are not turning up to work over and over again, I think to gently be able to reach out to them and see if their non-attendance is indicative of poor mental health. As the COVID-19 pandemic begins to recede, there's this idea of doing return to normal work interviews. So just checking in with people as they come back and asking how they're feeling, giving them that platform where it will feel non-shaming and non-blaming to talk about what this experience has been like. The fourth thing would be managers should pay particular attention to people at high risk groups. So junior or inexperienced staff who've been working above their expected level of competence. So this would be your interns, your students who have been thrown into this at a much higher level than maybe they were ready for. And then anyone who's been exposed to a potentially traumatic event should be actively monitored. So if you know one of your staff has been exposed to somebody with COVID, even if your staff tested negative, that's a potentially traumatic event. So really checking in on them. And again, the sixth one is kind of the same thing. Working with staff, asking them about their experiences, being able to develop meaningful narratives that don't blame people for how they feel. All of that's important to reducing the risk of psychological harm. And again, I think before I jump into kind of the conclusions here, so we have time for questions. So if your manager is using those six sort of factors to take care of your staff is important, but also to take care of yourself. I mean, make good boundaries. Just because you can do telemedicine at all times from anywhere doesn't mean that you have to see 12 people a day. You know, I think knowing where your boundaries are, knowing when you need a break, knowing when it's time to take a day off, meditating, self-care, all of these things are important. So, conclusions that we want to take away from today. The mental health care burden is great. The elderly are at especially high risk. Interruptions of normal care must be noted. Methods of care delivery must be reassessed. And provider self-care is key to manage the wave of cases coming. Because unfortunately, I don't think that we are anywhere close to out of the woods on this. And I think even if when we do start to come out of it, the long-term toll on the mental health care of us as a society is going to be felt for a while. So any questions? And Carrie, I don't know if people have been typing questions and you want to send them to me or how you wanted to do that.
Yes, thank you. So why don't I go ahead and read the questions to you? I have one here that's come up on the chat, and then I also have some to read off that's been texted to me. So first one in the chat box, are there any key terms or phrases you tend to hear that we should keep an ear out for that may flag someone who is depressed or struggling with isolation? Also, common terms to keep an ear out for with our caregivers that would flag that they might be overly stressed or burnt out.
Yeah, absolutely. So I think with clients and patients, the key terms that I've been noticing are people saying they're bored, you know, that they just don't know what to do. So I think a lot of times boredom can be synonymous with depression. So somebody who is constantly, when you're asking them, you know, what did I do today? And the common answer you're getting is, I didn't do anything. I feel bored, or I feel tired. I'm exhausted. I can't seem to do anything. I think terms boredom, exhaustion, fatigue, I'm just not hungry, or I can't seem to stop eating. I think some of these physical terms are the way that people are describing their depression and loneliness. Mm-hmm. So that would be for clients. And I think for caregivers, I think exhaustion, I mean, I think that people use the word fatigue and exhaustion, and what they really mean, and they do mean that, but what they also, I think, sometimes mean is that they're mentally burned out. That they physically feel like they just can't get up and do another day of work without a break. So I've been hearing that word a lot, just tired, apathetic, feeling like I don't want to do anything. I think those are real red flags for the depression that we're talking about.
Got it. Thank you. And then, so what are some questions that you might help us with in regards to what we should be asking on the care management side, or even our caregivers directly to our clients that are at risk or possibly showing increased mental health concerns?
I think I would start talking to people a lot more about their activities of daily living. I think that maybe what our clients do with their typical day, I think is something that we talk about early on with them in care when we're starting to get to know them, because we want to get a sense of how they're spending their day. And then maybe we don't talk about it as much as time goes by and we're dealing with other issues. But now I think it is important to ask your clients, what does a typical day look like? Because if someone says to you, I laid in bed all day and watched Netflix, I haven't taken a shower in 4 days, that's a real warning signal that they're not taking care of themselves. Or if someone says, I've been eating cereal every meal every day um, for a week, that's another sign. So I've found that just I'm talking a lot more to my patients about what they're actually doing with themselves every day. And if they tell me that they're laying in bed all day, then we're sort of really maybe taking a step back from dealing with some of the emotional stuff, but really putting practical plans in place, like coming up with a schedule of here's what time you're going to get up and here's you're going to shower and do this and this and that. So I think maybe focusing more on that than we would have in the past is important.
And I love that encouragement. I guess kind of a follow-up question to that is, the approach we then, from what we've identified and they, are at risk or the concern, kind of what is then our next steps?
Mm-hmm. Well, I think to increase services any way we can. So because yes, like I said before, the one-on-one telemedicine, that is important, and we should make sure that we're checking in with people regularly if we think they're at risk. But it also can't just be us, right? So it's unrealistic to think that we could spend all day on Zoom sessions with people. So reminding them that you can do occupational therapy over Zoom. You can do physical therapy over Zoom. You can, there are groups, support groups and meditation groups. So really helping somebody, especially if they don't have a ton of access to technology, working with their caregivers to figure out ways to increase that. Because really, if you can't leave your house because you're at such high risk for getting COVID, that is the only way. Using technology is really the only way that you can get the social interaction you need.
Mm-hmm. Mm-hmm. And a lot too, we've been talking about, asking questions and verbally what they're saying. So we are still doing in-home visits if, possible, but a lot of it we are trying to do virtually as well. Are there any, cues or signs that we should be looking out for as far as from the client and even the caregiver perspective?
You mean when you're going into the home, sort of?
Mm-hmm. Or even having like a virtual, what we call quality assurance visit.
Yeah, so I think really I've been paying attention to the way people are taking care of themselves. So I have patients where, before when they would come to sessions, always kind of dressing up or doing their hair or putting makeup on or whatever it might be, that was kind of their typical thing that they do. And if they come to a session and they're clearly disheveled, or somebody who was always super punctual and now is 20 minutes late, um, I think things like that are important cues that something is going on with the person. And I've noticed the thing about tardiness, especially because I have so many patients who it's like they pride themselves on being on time. That's like such an important thing. And so to have somebody who would never forget an appointment, who is always on time, all of a sudden they're no showing or they're forgetting, I think that's a really big indicator that something is going on.
Mm-hmm. Absolutely. Um, Another question I had that was sent in through text.
Mhm.
Let's see. What are some resources that we can provide to our caregivers or even our internal staff who are potentially burnt out or stressed?
Well, I mean, I think that depending on your agency and what you're able to do, I mean, maybe having increased staff meetings, I think is an important thing. So if you were only doing staff meetings once a month, to maybe do them twice a month to increase the forum where people can talk about how they feel. I think also to, you know, remind therapists that going to therapy is a great thing. So, starting their own therapy, joining support groups. But I really have found that increasing staff meetings and I've been making myself more available to the people that work for me, because I feel like sometimes they just need to know that they can text me and say that was a really difficult session. And I think that they are reaching out more than they did before, but I think it's a good thing. So I think for managers to maybe, so you don't burn yourself out, to build that time into your schedule a little bit more, and then to remind the people that work for you that you are there for them, and you are able, even if they just need to write a text saying that was a difficult day, I think to just let them know that you're a resource for them.
Mm-hmm. Absolutely. Let's see here. In regards to caregivers or community partners that may respond saying, I'm fine, when you can tell they aren't, what is the best way to push a little further? I worry with the stigma around mental health, it could be causing people to hold back on saying, I'm not okay.
Yeah, I think that is an issue. I think that's always been an issue. My hope would be that, because it's so much in the media right now, how this is impacting people's mental health, my hope would be that it's starting to normalize a little bit more, because I think every time you see a story on COVID, there's usually some bit in there about the mental health impact of this. So I would try to normalize it as the best you can before pushing a little harder. But if you think the person is really deteriorating mentally and you have pushed very hard and tried to normalize, depending on what your release of information looks like, I think getting their family involved, getting their other care providers involved, and trying to have a team effort is really the only way to go.
Sure. That was kind of like my next question is, what does that communication or approach look like from the family perspective, or any other, parties that are loved ones that are involved in the care that's being provided?
So what I've seen just in my practice, where I've had some older adults who, part of the recommendations of their neuropsych was to come in for therapy. And at the time they said, yes, I'll do therapy. That sounds great. Maybe they do one session and say, I'm fine. And then I get a call from their adult child a couple days later saying she's not fine. She's really upset. She's really hurting. So I think I've been doing a lot more family sessions. I've been doing Zoom calls where I am Zooming in the adult children, I am Zooming in other people, so that we can talk as a group with the patient. And I think that is helping to really just be transparent and open and say, let's just all talk together. Let's all talk about the concerns at once. I think that's been really helpful.
Absolutely. Can you share again with us, and I apologize, the recommendations of the different avenues or resources to utilize in regards to assisting with, the mental health? So the one that I remember was the Calm app.
Mm-hmm.
What were the other resources?
So I think in terms of the digital resources, there's an app called Headspace, which is really great. Calm is a good one. For cognitive rehab, there's an app called Lumosity that I recommend to a lot of different people. Right now, YouTube has a million different meditation channels, relaxation channels, deep breathing. So helping people, and especially older people who might not be as familiar with YouTube, to really show them how to find those channels and set that up. There's an endless hours of meditation and deep breathing that people can do for free online right now.
Mm-hmm, mm-hmm. It looks like, oh yes, Headspace. So that was a meditation actually Bridget was so kind to introduce us to on our last webinar. And so we all took a couple of minutes to just have our own meditation session. It was great.
Yeah, and I think that there are other paid apps like Peloton, for example. They're offering like free 30-day trials, and Peloton has everything. They have yoga, they have audio walking, they have meditation, they have everything. And a lot of those services that you normally have to pay for, during the pandemic, they've been letting people use them for free, which is really nice.
Awesome. Let's see. Bridget, I just want to make sure that I haven't missed anything. And even I know that you had sent me a couple questions. Anything else that you'd like to ask?
Just having a look here. I think we've covered the Sorry, there's a few questions now. I think we talked about, no, there's just a lot of great feedback on how great this conversation's been. And I think we've covered everything. I'm just having a quick look. But no, I think we're good to go, Carrie.
Awesome. All right. Well, if there's no further questions, Dr. Ioannidis, this was amazing and such helpful information, and things that we all can put in our personal lives as well to make sure for our personal, mental and health, emotional state. And so, thank you so much again for joining us today. It was beyond valuable. And I want to give a special shout out to Sandy Gunnett for connecting us. We couldn't have done this without Sandy. So thanks so much, Sandy. I think you're on the call today. We really, really appreciate you. And again, just as a reminder, we'll send out today's recording. And Dr. Ioannidis also gave us the green light to send over her presentation to you as well. So you'll have that coming to you shortly. So with that being said, thank you again. And I hope that everybody has a wonderful rest of their day as well as week.
All right.
Take care, everyone.
Bye.
Bye.
Take care.